to day 4 of Symposium. We're here today to have Dr. Sidonio present Women with Hemophilia. We're super excited for this presentation. It's been long awaited, and thank you for joining us this evening. Before we get started, I just wanted to do a couple of housekeeping items. You can see on the screen that these are the funders for Symposium 2021. Thank you so much for your continued support of this important event. I also wanted to say that if you have questions for Dr. Sidonio, you can place them into the chat. The chat is visible only to hosts and panelists, but we will be looking at those questions, and at the end of the presentation, we'll ask those questions of Dr. Sidonio. And additionally, if you have any tech questions or need support, you can put that into the chat as well, and we'll be sure to try to help you out with those. So with that said, I'm going to exit out of my screen and give the screen over to Dr. Sidonio.
So thank you very much for allowing me to talk today virtually again. Hopefully this will be one of the last virtual meetings that we do in a little while. We're hoping for a non-virtual 2022 year. But either way, it's still good to get this message out and hopefully do remain it hybrid. But today, the task is really to talk a little bit about hemophilia carriers, women with hemophilia, and everything in between. Many of you have seen this slide, but it's really important to understand the exponential growth of hemophilia carriers and women with bleeding disorders, and the fact that the growth for this group is outpacing the growth of the overall general population by at least 3 to 4-fold. And we should be getting data from Judith Baker soon about what 2020 looks like. I'm sure the trend will continue. We know that when we talk about hemophilia carriers, women with hemophilia, there are probably at least 800 to 900 patients that have been documented in this country. Probably, if I had to guess, there's probably about 1,500, 2,000 in the country. But we have what we have from the data sets. Certainly when we talk about hemophilia carriers, women with hemophilia, we know that the majority of those either have normal levels or they have mildly reduced levels. And that's reflected here in the Athens data set, in which the majority have mild deficiency, meeting the same definition as before. And it's no different in the hemophilia B carriers or women with hemophilia B, in which we have very few with severe and moderate disease. Most of those have Turner syndrome or exochromosome, and a couple of them will have some other varieties of that with mosaicism and such. But the majority are going to be mildly deficient or normal. And I have another study that shows that. One of the most interesting things that Connie Miller's paper came out recently demonstrated from the CDC community counts. And so before they were seeing, we were stating that from Athens data set. But when you look in CDC community counts, there are about 51 females with severe factor 8 and 9 deficiency, 80 with moderate to factor 8 deficiency. So that's about 130 with moderate to severe, and about 1,500 with mildly reduced deficiency. And if you look overall, about 1 in 5 mild hemophiliacs is now female in this country, something worth acknowledging. Clearly, we talk about moving the needle. I think there clearly needs to be studies in non-severe hemophilia in which males and females are included. And particularly we'll need to have a special design for women because heavy menstrual bleeding is hard to quantify, when it comes to ABRs and annualized bleed rates that we use in severe studies. So typically we like to do a couple of cases. It helps us illustrate the issues. So we're talking about a 34-year-old female who wants to deliver a child. Ultrasound confirms that it is a female gender, genetic gender. The father has severe hemophilia, and there have been previous male child without hemophilia, and mother has no known history. So when we talk about inheritance, if your father has hemophilia, then all the women are obligate carriers. If the mother has it, then it's a 50-50 chance that the daughters will be hemophilia carriers and a 50-50 chance that the males will be affected. We use the term obligate hemophilia carriers when we're talking about a daughter of a male with hemophilia. If you're a mother and you have two sons with hemophilia, or if you're a mother with a male with hemophilia and another relative. And we use the term possible when we're talking about a daughter of a female carrier, a mother of a male with hemophilia but no other family history, and then a female relative of a male with hemophilia. So that's when we use the term possible hemophilia carrier. There are many other ways of developing this. We know that skewed inactivation, meaning X's chromosome is inactivated in a random fashion, and it may skew one way or the other. We know that it's possible to have two variants. You could have consanguinity, in which you're marrying somebody closely related within the family. You could have a new variant, and you could have a previous variant from the family. You could have two new variants develop, which would be highly, highly rare. And then you can certainly have two different variants, which can happen if you have a male with hemophilia and a hemophilia carrier that get together. And clearly you can develop a de novo other variant. And then you can be exochromosome or Turner syndrome, in which you express this. We had a carrier a number of years ago, one which died of intracranial hemorrhage from severe hemophilia, unknown, but known to our clinic. And another one that currently has severe hemophilia is actually on emicizumab for management, being managed like any other severe hemophiliac. We know that you inactivate the chromosome, and this is obviously important. And the choice of which one happens clearly is different. And when you're looking at this type of cat, you can see an example of an X-linked inactivation visually displayed on the fur, in which there's black and orange fur, and you get this typical distribution of a classic cat like this. And so this is, something we wish we could see. We know that lionization occurs probably differently throughout the body, and it isn't really clear, and this is an area under investigation. So going back to the mother, all of the female children will be carriers, obviously, if you have a father with it. Unless there's a concern for Turner syndrome, it's okay to defer testing until 6 to 12 months of age. And the decision could be vaginal delivery. It does not have to be exclusively C-section when you're talking about a female child. So what about preventing and mitigating bleeding? Well, when you talk about what to expect in hemophilia carriers or women with hemophilia, in this study done back in 2006, the level was about 60%. They had carriers with levels in the moderate range, 5%, so women with moderate hemophilia, those with mild hemophilia, and then we had symptomatic and asymptomatic carriers. And we know that with bleeding with small wounds, there's going to be bleeding with dental extraction, with the procedure and requiring intervention, and certainly with surgical procedures requiring blood transfusions. And certainly if a woman has hemophilia, that's not surprising that they bleed. It's more interesting to me, the bleeding that happens, because they have levels that are in the relatively normal range of 40 to 60%. And that's the group that I think is vulnerable and needs to be protected. We know that when you look at a correlation between phenotype, or the bleeding symptoms they have, and those and the levels, we know that when you look at, for example, in this study, it doesn't seem to exist. So a mother with severe hemophilia isn't going to bleed any differently than a mother with moderate hemophilia. And furthermore, those severities will not predict their levels that they're going to have. We know that the bleeding scores are elevated in hemophilia B and A carriers and compared to normal women. And this has been demonstrated in multiple studies, including the study that we did years ago, in which the carriers' bleeding scores were elevated. This was corroborated by Paula James, by Peter Seigan. We all had approximately the same bleeding scores, around 5 to 6, compared to normal women. And all of the studies also demonstrated elevated menstrual bleeding scores compared to normal women. What kind of bleeding risk do you see? Well, this is a paper recently published and also included in a chapter that we're writing in Textbook of Hemophilia. When you look at the bleeding tendency, as mentioned before, dental extraction, surgery with delivery, joint bleeds, for the most part, nosebleeds, and heavy menstrual bleeding as well. There's some overlap because we know in normal women, heavy menstrual bleeding and nosebleeds can occur as well, but certainly there's a higher risk. So why do these carriers bleed? Well, we've done a study in 2018 looking only at hemophilia A carriers. The idea was that it wasn't a static issue, that women with hemophilia or carriers, it isn't just their level that predicts the bleeding, it's their ability to elevate the level in the setting of stress from injury that predicts it. And when you look at hemophilia carriers as a whole, they're not able to elevate their levels compared to normal women, and certainly aren't able to sustain their factor levels at 4 hours in the face of stress. In this study, we used Ddavp to emulate stress. That doesn't explain why hemophilia B carriers bleed, but they aren't able to elevate their levels, so potentially they're maybe at higher risk for bleeding. Dr. Peter Seigan is further evaluating this, and he's trying to create models. This is part of a mentored research award he has. He's trying to incorporate X-linked inactivation assays, factor VIII levels, and hopefully we'll be able to get more data in this in the future. So what about mitigating joint bleeds? Well, we know that joint bleeds can occur. They seem to occur approximately 10 to 15% of hemophilia carriers. Most of the carriers only have 1 to 3 joint bleeding events in their entire lifetimes. So it really isn't clear whether prophylaxis will prevent all of this. It may mitigate it in some situations. We know that joint range of motion, which is a surrogate for joint bleeding, acknowledging that over time, your joint range of motion decreases. That happens with everybody. When you look at the normal study, you can see over time, normal women, their joint bleeds reduce. But if you look at carriers with normal levels, women with mild deficiency, women with moderate and severe deficiency, there seems to be a further reduction in joint range of motion. Whether this is clinically significant is still not very clear, something we've been trying to prove in studies. But this is from the CDC study, and this was data gathered from the community counts, or universal data collection rather, that was done years ago. The reason we don't have a lot of data in the moderate and severes at this age group, because many of these women were infected with HIV and hepatitis, just like their male counterparts. And thus we don't have a large number of patients to get consistent data. To further demonstrate the risk of joint bleeding, we decided to do a multi-center study, which was published. We presented this at NHF, but we know that joint bleeds do occur. In these 23 carriers, 9 joint bleeds were reported over a period of a couple of years, most consistently in the knees, ankles, and elbows. All of them experienced in the hemophilia A carriers and none within the hemophilia B carriers. Looking at another data set, at the Athens data set, focusing exclusively on women, we know that joint bleeding does occur. Overall, it occurs in about 8.6% of all women with bleeding disorders, the rate slightly being higher in those women with hemophilia A and slightly lower in those with hemophilia B, certainly occurring in von Willebrand's at a similar rate, particularly those with severe disease and those with Glanzmann's and Bernard-Soulier disease as well. One of the most complete studies, and we're trying to replicate this with a Dutch cohort, is a Swedish study in which they looked at patients over 22 years. So they took all of the hemophilia carriers, those with and without factor deficiency, and they ended up with 50 with levels of less than 40% and 160 with levels over 40%. If you look at the distribution here, you can clearly see you get a nice normal distribution curve, exactly what we predicted a few years ago. Most of the women have levels in the 40 to 60% range. Some of them are normal and have very little bleeding, and some of them are reduced in the single digits. We know what we learned from this is that carriers with levels less than 40% were 2 to 3 times more likely to have joint bleeding events associated with diagnostic codes, and 10 times more likely to have joint surgery compared to normal women. I don't have this data on here because I think there's still an embargo, but if you stay tuned, you'll see additional data at ASH and in upcoming papers on joint health, in which Dr. Divya Sitla will demonstrate that we are seeing some joint health and bone health issues in hemophilia carriers as well, according to a national claims data set. So we're working on getting this published, but certainly we see some similar results as they saw in the Swedish cohort. Our data isn't quite as clean as this cohort, but certainly shows and demonstrates the trend. So a lot of women are asking about, why can't I get factor prophylaxis? Well, if you look at males with non-severe hemophilia A, they make up 50% of the population. We know that prophylaxis certainly is very common in severe deficiency, in which you see the majority on prophylaxis prescribed peaking out at 97% before they become adults, and then slowly they stop using it until it's about half the percentage as elderly men. If you look at moderates, it's about 52% at the peak in pediatric age, and then continues to about 30% in older age. And not to be outdone, mild males with hemophilia, up to 10% are on prophylaxis at some point. And so there's no reason to think that somewhere between 5 to 10% of women with mild hemophilia A may benefit from prophylaxis, even if it's short-term for 6 to 12 months to break bleeding patterns. So something that's worth considering, and hopefully there'll be some clinical trials moving forward to look at this. I've lobbied with industry to look closer at this and have provided them with this data. So hopefully in 2022, we'll see some studies coming out. And certainly there are companies that are interested, and certainly there is a Hemlibra study looking at Haven 6 looking at Hemlibra in women with mild hemophilia. And this study is enrolled, and there are very few women with hemophilia that have participated in it. And even at our own center, we've had multiple women turn it down. And so, I think as a whole, as a community, we have to have women enroll these studies, or it's not, one, we're not going to see that there's a interest clinically, and two, we're not going to have data to prove to the FDA that there's a clinical need. So when we're talking about management of bleeding, certainly Ddavp can be used in hemophilia carriers and those with mild deficiency, and obviously those that have moderate and closer to mild, closer to moderate would benefit from factor in both hemophilia A and B. So going back to the carrier, what about testing? So again, if I didn't mention this, this is from a Japanese manga. I have the website on here, written specifically a graphic novel written about hemophilia carriers. And so when do we send the testing? Well, prior to the first period, prior to any procedures, and following any significant bleeding episodes. What about hemophilia B carriers? Well, you should send the one-stage factor IX assay. And certainly the chromogenic assay probably doesn't have much utility in this group. It should be sent on more than one occasion. And then hemophilia A carriers used to send both the one-stage and the chromogenic assay. And it should be sent at a steady health state when the patient isn't very anemic, isn't ill, doesn't have a cold, and should be repeated on another occasion. Genetic testing doesn't have to be done earlier in hemophilia carriers, certainly should be done in consultation with the teenage girl to ensure that genetic counseling is done with the genetic testing. And you should consider treatment if levels are less than 60%. Obviously, inhibitor testing, I get asked about this all the time. It should rarely be sent. It really shouldn't be sent unless there's a clinical concern or if you have moderate to severe disease. Sending it in a woman with mild hemophilia probably doesn't make a lot of sense because it's rarely ever been reported. Certainly hasn't been seen in the CDC community counts, and really is very unlikely to happen. Something to think about, unless there's a specific mild mutation that's associated with bleeding. So when we do evaluation for women with hemophilia or hemophilia carriers, it's important to consider von Willebrand disease. It's common enough for us to consider. We typically send other screening tests as well to investigate for other bleeding issues to ensure that there's nothing else going on. and certainly would consider other specific factor assays. If your PTT is prolonged, you may want to consider the factors within that intrinsic pathway, and they're listed here. Or if the PT is prolonged, you may want to consider fibrinogen or factor 7 as a cause. And if they're both prolonged, then you want to think about the common pathway 10, 5, 2, and 1. And factor 13 is rare, should only be considered in life-threatening bleeding events, or if there's no other good explanation for bleeding. And certainly platelet aggregation studies may be beneficial. I think oftentimes they aren't productive. They don't really explain additional bleeding. And I think people use it as a way to explain bleeding that probably isn't. It's rare that it changes the diagnosis to the point where it explains the bleeding. There's a lot of people with mild qualitative platelet function bleeding that probably don't have a platelet disorder because the testing isn't very good. And we're probably going to largely, hopefully, replace it in the next 5 to 10 years. So going back to the patient, the PTT is prolonged to 41 seconds. The chromogenic level is 30%. The one-stage level is 45%. So that's the typical just on the factor VIII level. Had normal von Willebrand studies. So this is a woman with mild hemophilia. She's also a hemophilia carrier, and that should be denoted in her chart. So let's move on to the next case, a 7-year-old obligate carrier that needs a tonsillectomy. Well, her levels are one stage of 40%, chromogenic of 32, and a PTT that's either normal or prolonged. That's not really relevant in this case. So what do you want to do to prevent bleeding? Well, certainly if you look at guidance on dental extraction, it's not exactly the same. There's a role of potentially using IV Ddavp, and certainly could consider using, low doses of factor VIII as well. Typically, we're going to use mostly standard half-life products. I don't see that there's a large role of extended half-life products in this. It's probably not going to be that beneficial. Certainly, there may be some patients on it, but you can certainly just give a higher dose of standard half-life product to make up for the very incremental benefit for extended half-life product, typically in a mild patient particularly. Tranexamic acid should be strongly considered as well. And so what do we want to do in mild to severe hemophilia? Well, we should think about what would we do for a male on this. And so, well, when we talk about antifibrinolytics, Amicar and tranexamic acid work really, really well. We can use it alone in mild deficiency or use it in combination with Ddavp or factor. High dose Ddavp should be considered. We can give it intravenously. We have a source with Stack Pharma to give it intranasally, and we certainly can give it sub-Q as well. Dr. Allison Wheeler in Vanderbilt has a lot of experience over the pandemic of giving this. We want to acknowledge that an adequate response means that you have a level over 50% at 1 and 4 hours, and you can go from there on whether they're responsive. And certainly factor VIII deficient could consider, if lack of response or contraindication, you could give factor replacement depending on how deficient you are. Ddavp is utilized in a lot of males with mild hemophilia with similar levels, so there's no reason we couldn't use it in this situation, but certainly couldn't use Ddavp and in those with factor IX deficiency. So going to that woman, that teenage or young girl with mild hemophilia, we gave Ddavp. You certainly could give sub-Q. We give it 60 to 90 minutes before the procedure, and then give antifibrinolytics pre and post. And it's really important to give it up to 10 days. I know a lot of people with mild von Willebrands and some carriers are given multiple doses of Ddavp. I think there's absolutely no benefit of giving additional doses. I've seen that done. I've never done that. I've never had an issue with it, giving it a single time, particularly if you're giving the antifibrinolytics. So moving on to heavy menstrual bleeding, and we're talking about obligate hemophilia carriers. So this patient has a one-stage factor VIII level of 30 to 40% and a chromogenic. And I know there's a question about factor IX chromogenic assays. They're just not very good right now. they're not well validated, and they're hard to order. So right now for factor IX deficiency, all we really have is the one stage. And so it's hard to order, and it's not really clear that it's any beneficial in hemophilia B. So her period started at age 11. They got heavier at age 13. She was started on a progestin-only therapy called agestin. She had a lot of emotional changes, didn't like it, then was switched to a combined oral contraceptives because of breakthrough menstrual bleeding. And so the question is, how do we manage the heavy menstrual bleeding? Well, there's lots of ways of doing it. And heavy menstrual bleeding is incredibly common in carriers, certainly very common in normal women as well. So people need to acknowledge that as well, for sure. We know that anovulatory bleeding is very common, and that's when there isn't ovulation or release of the egg. And so there's no corpus luteum to secrete progestin. Estrogen is unopposed. And what you do is you get this very proliferative endometrium that builds up and just builds up. And you may have multiple months in which you miss menstruation. And then finally, you have a really bad period that lasts like a month or two. And it's very difficult to treat with hormones. Initially, it does take many weeks before it becomes better. We know, looking at our data, we don't track this very well in the Universal Data Collection Project. Certainly don't track birth control use in the Athens data set like we should. And we know that birth control use, agestin use, desmopressin, Amicar, and Lysetta are very commonly used. We know that in von Willebrand's, concentrates are being used more often, and there's some data to demonstrate that. We have utilized IUDs in hemophilia carriers, Depo-Provera, agestin, combined oral contraceptives. All of them have been effective, and certainly there's a small portion of patients that did not respond. We have a hemophilia A carrier who is a woman with, now currently a woman, she's an adult now, with moderate deficiency that's on agestin and has been on that for many years and has done well without hardly any factor concentrates for her menstrual bleeding. So you can get away with some hormones in some patients. Certainly, we want to look at all the different ways. We do have some guidance on it. And so, it's certainly reasonable to consider other options as well listed here. So going back to the female with mild hemophilia A, well, it's not really clear whether prophylactic factor can reduce this. We don't have any studies to demonstrate this. There may be a few patients here, but I can tell you multiple patients that did not respond to this. And so we really need to do studies on this. I attempted to do a study years ago and had almost nobody that was interested in enrolling the study. And so I had to shut the study down. And so we really need to get some engagement and try to get involved in national studies on this, because when the studies fail, then industry and the community think there isn't an interest or a need. So right now, IUDs are definitely considered on the table. Hormonal therapies should be considered. When those fail, factor therapy may be considered, potentially giving it on day 1 and day 3, and potentially day 5 or 6 if needed in situations. Those with normal levels, I think it would be very difficult to do that. Certainly those with mild deficiency, there's a role of giving low dose factor with close evaluation to see if there's an improvement. So moving on to a carrier that's pregnant and wants to deliver a child, certainly heavy menstrual bleeding managed with agestin was stopped 3 months prior to planning. She's had hematomas from softballs. She's had a wisdom teeth extraction treating just with antifibrinolytics. So this woman with mild hemophilia B has done generally well with minimal intervention. Postpartum hemorrhage is probably higher based on our limited data. There certainly are studies to support both methods. There are competing papers written by Dr. Andrew James and Rolf Leung from Sweden, both of them advocating for one way or the other. I don't think you absolutely have to have a C-section. I think if you certainly know if you're going to have a male with hemophilia, it should be considered. If you're doing vaginal delivery, it should be a very early conversion. If anything goes wrong, you should not wait for very prolonged, difficult labor before you convert. We know that carriers, when you look at time over their pregnancy from the non-pregnant to the third trimester, factor 8 levels go up approximately 2 to 3-fold. Factor 9 levels don't change that much. They may change by 5 to 10%, but not a lot. And certainly that happens over the trimester. When you look at studies, our study in 2015 said it was about 30%. Other studies have shown somewhere between 10 to 30%. So probably somewhere in the 20% range is likely what it is for postpartum hemorrhage. And what can we do? Well, we know Ddavp given procedures can increase and lead to hemostasis. There's limited data to support reduction of postpartum hemorrhage as a strategy. Factor can be used, certainly should be considered with antifibrinolytics, and fibrinolytics should be strongly considered in most situations. That's recommended in this guideline document from 13 years ago as well, either Ddavp, tranexampin, acid. There's some people concerned when there's a C-section that you aren't able to effectively fluid restrict because there's a lot of fluids involved in C-sections. So what about prevention? Well, liberal antifibrinolytics should be used. Factors should be available. You should know what the levels are in the first and third trimester, so you can plan for this. Again, 1 stage in factor 9 deficiency and 1 stage in chromogenic and hemophilia A. Optimal mode of delivery should be C-section. Monitoring should be done closely in the 5 days. Shouldn't use forceps, vacuum, or fetal scalp electrodes, and consider keeping the levels over 50%. One of the things, wrapping this this presentation up, because we'll need to go to questions soon. We know, and we proposed this a while ago, but certainly we are seeing that we know that carriers have a normal distribution. There's a lot of discussion over the name and a lot of anguish over the name symptomatic carrier. That should be an appropriate term if your levels are normal and you have bleeding. And so we sought, and we did publish a paper. Karen Von Galen was the junior person. Now I'm the senior author. I guess I'm old enough to be the senior person now. We decided that we wanted to improve the communication, come up with a standard strategy. I would have preferred using a cutoff of 50%, but we had to use a cutoff of 40% since this is an international group. But women that have levels over 40% and don't bleed, using the term asymptomatic hemophilia carrier is totally appropriate. If they do bleed and they're over 40%, it should be labeled as symptomatic hemophilia carrier. Certainly women with levels between 5 to 40% should be called women and girls with mild hemophilia, women and girls with moderate hemophilia, and those with severe hemophilia. I know there'll be some questions about gender equity and trying to be sensitive to issues of transgender. I think it's really important to denote gender on this one when it comes to women, because there is a difference. The bleeding symptoms are different, and the bleeding is different, managed differently when you have a woman with mild hemophilia versus those with males with mild hemophilia, because we have to consider the different hormones. We have to consider the risk of being on birth control and thrombosis. And so I think it's important to maintain this, certainly acknowledging our LGBTQ members, but it is important to denote the gender here moving forward. Certainly we can talk about how we could be inclusive in the future, but it's important to denote the differences in bleeding between men and women. Certainly our initiatives in the United States aren't the only ones. I'm glad I have a lot of partners over in the European space, and there is the European Principles of Care for Women and Girls with Inherited Bleeding Disorders. And they've set out to ensure equitable access, timely diagnosis, awareness of challenges in women and girls with bleeding disorders, ensuring a dedicated GYN as part of the team, having a comprehensive approach, having preconception counseling, and improving the involvement in registries and clinical research. So this is an initiative that's ongoing. Karen Von Galen or Dr. Von Galen is involved in this, as a number of other my female colleagues and a few male colleagues over in Europe. So this is happening throughout the world, and certainly it's reasonable. It's an initiative as part of we've discussed at ISDH. So thank you very much. I had a limited amount of time to discuss these because we wanted to open it up for questions. And I think we have some time, about 10, 15 minutes to get to questions. So thank you.
Thank you so much, Dr. Sidonio. That was great. We do have a number of questions that came through
Sure.
in the Q&A. Hopefully we'll have time to get to them.
Sure. Yeah.
So the first question that came in was, what do we do to protect baby girls at birth who may be obligate carriers or have a 50% chance of having the gene from their mother? Some hematologists have said they should have 50% factor and do not need to be tested until they are older. How do we encourage medical professionals to test girls in infancy as we would the boys?
So I agree that we should consider it, but the majority of hemophilia carriers have levels in the normal range. It's reasonable to test those children in the first 12 months of life. I certainly don't think they need to be tested immediately after birth, unless there's bleeding issues, or unless they know there's genetic conditions like Turner syndrome. And there's been very rare instances in which we've seen bleeding in non-Turner syndrome patients that are carriers early in life. Certainly, if there's a surgery that has to be done, procedures that have to be done, it's reasonable to do that. But genetic testing should be deferred until later, hopefully having a discussion with a young girl or young woman about this. But yes, it should be considered early in life, but certainly doesn't have to be done immediately, can be done in the first 12 months of life.
Okay, thank you. The next question is, do you believe the joint bleeds reported in women are accurate or underrepresented due to barriers in access to care?
Well, since most of the women have mild disease, I think the patterns are similar that you see in males with mild hemophilia. Majority of males with mild hemophilia will have joint bleeds every few years, typically. They may have more. We certainly have some mild hemophiliacs that have severe disease and require prophylaxis, but the majority of males with mild hemophilia rarely will have any joint bleeds prior to age 18, but certainly will have reduced joint range of motion. I think it happens. I think problem is that it's hard to prevent it when you're talking about majority of women and girls with mild hemophilia will have less than 5 to 6 joint bleeds before they become adults. It's very difficult to prevent that. Long-term strategies, the majority have less than 2. And so it's really hard to prevent that and come up with strategies to prevent that. Certainly it should be documented, reported if it happens close in proximity, or if the levels are lower, certainly in the closer to moderate range, then consideration for prophylaxis can happen. We all acknowledge that any woman with that is a carrier, and certainly those with mild, moderate, severe deficiency should be considered seeing an HTC at the same frequency. But I can tell you, we had a couple of mild hemophiliacs today. Majority of the mild hemophiliacs do not want to be seen very often. Want to be seen less than once a year. We have to drag most of them in to be seen once a year. And so certainly once a year or once every 2 years is a reasonable frequency.
Thank you. What is a chromogenic factor 8 assay and why would we need one for factor 9?
Yeah, I sort of alluded to that before. So the chromogenic factor 9 assay isn't very good, so it's not going to be recommended. It's not really standardized. So this is a different way of measuring factor 8. And it's debatable about which one is more quote unquote accurate. If you're on, for example, Hemlibra, the only way to measure your factor 8 is to do a chromogenic assay. So if you've been on Hemlibra, the only way you've been able to accurately measure it is a chromogenic assay, specifically with cow or bovine components. So it's the standard that we use typically when we have drugs. It's usually a more expensive assay, not always. It is more difficult to do. And so it isn't always what we do because it's not as easy to order, but there often is a discrepancy, and it could be either higher or lower or it could be in the same as your one-stage assay. And so it's good to know if there's a discrepancy. Certainly, we use it when we enroll patients into males into pup studies. We use it. It's just another way of measuring factor VIII and should be considered.
Thank you. Has this great information on symptomatic carriers with factor levels over 40%, but that have the bleeding phenotype, been disseminated to our HTCs? And if not, is there a plan to integrate this into clinical practice across the United States?
Well, I mean, we published it, we've mentioned it at multiple meetings, and certainly have discussed it in multiple settings. We discussed it at MASAC, discussed it at NHF meetings. And so, I mean, it should be the standard, and there's going to be, I think, a comprehensive, another model. It discusses it. It's something we can certainly bring up at MASAC at the next meeting. Certainly, we're revising some of the upcoming guidelines, and WFH has generally integrated that into their model as well. So there's plenty of papers out there supporting it. It's just a matter of whether, places, I can't force people to do it, but I certainly can strongly suggest it, and hopefully people will do this. So yes.
Okay, thank you. As you spoke on genetic testing, should levels be tested again for von Willebrand severe once they start their teenage years? And will the levels change once puberty has started?
Yeah, so for severe von Willebrand's, there isn't always a role for genetic testing. I personally feel like there's a benefit when it comes to severe von Willebrand's. Genetic testing is a little bit different in that we certainly recommend doing it in certain subtypes like type 1C, type 3. There definitely is a benefit because you could evaluate whether there's a risk for inhibitor, which are extremely rare in severe von Willebrand's. If you have very severe von Willebrand's levels that are consistently less than 20%, it's not going to change much as they get older. People with levels of 30 to 50%, it will definitely change. Most of them will have elevation, and sometimes the levels will go up to the point in which it's almost normal by the time they're adults.
Thank you. How do we advocate for ourselves when we are the only females at our treatment center and they do not know what to do with us because we are mild? Men are not treated the same and do not have the same problems.
Well, we typically just, state that, forget about the gender. If you have somebody with mild hemophilia, what would you do? Obviously, you have to factor in hormonal therapies because there is a risk for thrombosis that we have to consider. But there's no reason that anybody with mild hemophilia should be seen in the center. It should be seen at the same frequency. We talked about the low need for prophylaxis. Only about 10%, 15% of mild males are on prophy. So the majority of women probably shouldn't be on prophy, but certainly a small portion could be considered. And so, it's really just a matter of documenting bleeding, and encouraging the nurses to attend, sessions. I mean, there's not much else I don't know how else to advocate anymore for that. So.
Okay, thank you. In your opinion, how can we boost the number of studies for women with mild and moderate hemophilia?
Well, we have to have women participate in those studies. We've had a couple of studies that are open and women are not participating in them. And so including Haven 6, there's a very small number of women with mild hemophilia involved in that study. We had trouble enrolling any patients in that study at our center. I had a study for heavy menstrual bleeding at our center and only could enroll 2 patients in it. And so we have to have more engagement. There are a lot of women say they're interested, but then when it comes to actually asking to participate, to come to the clinic visits, to be stuck, the number goes down to near 0. And so industry is interested, but if they don't have a lot of engagement or people not stepping up. And so we really need to do that. I don't think it's just because of childcare or travel. I don't tell people they can't, I say they can bring their child. It's the reason you can't bring your child to a research visit. We're at Children's Hospital. In these adult hospitals, I've had people bring their kids and there's no reason they can't be there with them. Certainly it's not always the best, but it's definitely a need for it. I think a lot of women want to just be treated and managed in the clinic, but we have to do well-organized studies just like we did for the men. Otherwise, we're not going to get any data. That's the only reason we got good data on COVID, and anecdotal data is not going to change the way we manage things. It's just going to lead to frustration. And so I'm hoping that a couple of companies are interested in doing more studies. You can go on clinicaltrials.gov and look at Haven 6, where it's being enrolled. And hopefully there's a couple other studies that will be open as well. Look at mild hemophilia and look at the gender inclusion on there to see if you would qualify. Most of the studies have removed the gender as a restriction, but certainly there's some guidance on preventing pregnancy. There's some challenges. You cannot get pregnant on these studies because we have limited data on neonates, and so it's really important. So
I think we have time for one more question.
Sure.
My mother and niece are both expecting sons and have hemophilia, and hemophilia B is a family trait. I understand there's a 50-50 chance their sons would inherit hemophilia B. What steps should they take toward the birthing of their sons?
Well, they should definitely confirm with a genetic counselor what type of hemophilia B and make sure it is hemophilia B. And so certainly confirming that, whether they're an obligate carrier or a possible carrier. Genetic testing can certainly be done. The level of the carrier should be done in the first and the third trimester. And, and there should be discussing with your hemophilia treatment center to have a plan in place to ensure, and you should have these things before the actual day of delivery. That's a very chaotic day. We need to have a plan to do cord blood testing because most women are not born in academic hospitals. They're born in the nicer, better, private hospitals that have better birthing suites and nicer rooms. They're born there and they aren't always prepared for that. So having a plan to do cord blood testing, having those, in place, avoiding vacuum extraction, all those things. So all you have to do is talk to your HTC and they can send a letter with a birthing plan, what needs to be done, documented in the chart, have it in your hand when you take it to see the GYN for talking about in your first trimester. So planning is important, not waiting till the last day. I don't know how many times I get phone calls for somebody that's in delivery, actively delivering, and they want to know what to do. That happens too much. We don't need to do that. So.
Well, thank you so much for such a fantastic presentation, Dr. Sidonio. You may see in the chat that there is a number of people that commented to thank you for all the important work that you're doing to advance all our treatment and access to care for women. So thank you very much for that. To the attendees, I just want to say you will receive an evaluation at the end of the session. It actually will show up in your browser, not in Zoom. So please check that. And if you put your name at the end of the evaluation, you will be entered into the drawing. The next session for this evening starts at 6 p.m. You can just go back to the website and find the link there for where you can click to the next event for this evening. But thank you again, Dr. Sidonio. I really appreciate it.
All right, have a good evening. Thanks, everybody.
Bye.